And thank you all for joining. Give me just a second to find and share my slides. There we go. You should now be able to see the slide. Dominique, if you could give me a thumbs up if that worked.
Yeah,
okay.
You're all good to go. I see it.
Thank you. I will say first off, thank you for the kind invitation, but also thank you to all the attendees, recognizing that being part of the Spark community hopefully is a positive experience, but really is also a contribution to the world at large, recognizing that only through research do we get new information. So thank you for being part of that community. I am going to go pretty quickly, particularly through the first bit of the talk, because I want to leave some time at the end for questions. But as I put the talk together, I realized there's also a fair bit of information to share. Please don't feel like if I'm going quickly, that means you're missing things. The slides will also be shared, and you're certainly welcome to rewatch this if there's specific information you're more interested in. I just want to be clear that I'm sharing as much information as I should be. I also want to note that it's always important to provide disclosures. So I have had a variety of different funding sources for research that we've done over the years. We've also participated in a number of clinical trials that are funded by pharmaceutical companies. None of those have yet translated into the clinic, and I actually don't think I'm going to be talking about any of them, but if something relevant pops up, it'll be in red at the bottom, and happy to discuss that in the question and answer period as well. So I think at the front end, and I'm not going to spend a lot of time on this, but it's important to acknowledge that autism spectrum disorder is a DSM, a diagnostic label that we use, and we use because it allows us to think about a group of people who do have something in common. But they don't have in common a clear mechanism. It certainly isn't something that we would think about as a disease. Some people use the term condition. And when I think about autism as an entity or a word that we use, we're really describing core difficulties in social communication and repetitive behavior. And when I see a kid who has an autism diagnosis in my clinic or an autistic adult in my clinic, I never see somebody who only struggles in those areas. A broader description of what somebody is dealing with is always needed in order to understand how we might be helpful to them. And somebody could fit this pattern, difficulty with intellectual disability, maybe a genetic condition, some co-occurring medical problems, or this pattern. And you see differences in core symptoms, but also differences in associated symptoms or difficulties. And when I'm telling you about a study that's been done in autism or a potential treatment in autism, we're lumping folks together with many different patterns and saying what helped some of them. And I think that that's important to acknowledge. This isn't perfect. We need to get to a place where we have clearer definitions, but at the front end, I just need to make sure that I'm clear about that. So what I'm going to try to walk through is first, very quickly, what we know about medicines in autism spectrum disorder. I'm going to be really talking about needles of evidence in a haystack of uncertainty. Most of what we would like to know, we don't know. And then I'm going to talk about when, why, and how we consider medicines, not comprehensively, but giving a sort of approach that I think about using. And then use a fictionalized example to make one key point in particular. So those needles of evidence, I will first say, even though this is a talk on medicine, the treatments that we should be thinking about first are behavioral interventions. And that's because our evidence is quite strong for early and intensive behavioral or developmental interventions. These are things that are usually 12 to 40 hours a week. Most of the evidence is before about the first grade. And the benefit is seen really in measured IQ, as well as language and adaptive function. These are interventions that can have a profound impact. There are also other behavioral interventions with some evidence. And to just provide, a graph that shows what we're talking about here, you can see the group that was actively treated, and this is using the Early Start Denver model approach, actively treated in a university setting, gaining more than a full standard deviation, so more than 15 points of IQ over the course of treatment in comparison to folks who were treated in the community. You can see there also is some improvement in adaptive behavior. So important to just say that at the front end. On the medication side, what we know is in a couple of categories, both what can lead to benefit and what clearly doesn't. It's instructive to recognize that the two medicines that have actually had the most independent, randomly controlled trials, where you have a placebo compared to active medicine, neither one seems to actually lead to significant benefit. I'm going to talk later about oxytocin, but I'm going to talk first about secretin, in part because it's easier to look backward and well backward than it is sometimes to look forward. So secretin was a fad treatment in the late 1990s. It was covered on 2020, 60 Minutes. It was something that probably tens of thousands of kids in this country were exposed to as an IV infusion. There were then 7 well-conceived placebo-controlled studies, and these studies showed universally that it led to no benefit when compared to placebo. And we need to really internalize that we can't draw conclusions until we have controlled studies. And I'm just going to give you an example of one of those studies where you see here 2 groups. This group received a placebo infusion, and this group received a secretin infusion. And this was a total score used to rate autism symptoms. And you see that the placebo group actually showed a bigger improvement that persisted across those 4 weeks in comparison to the secretin group. So that if you didn't have 2 groups, if you only had one, and it could just be the placebo group, this could be something that we all would think would be a quite helpful treatment. I think it's important to note that placebo has a big effect. That doesn't mean it's just about hope. It can mean that parents are seeing, clinicians are seeing the evidence of continued development, even in somebody with a developmental disorder. So absolutely, there are improvements. Those can look like important improvements when you're trying to assess whether a treatment works. But in this case, those are improvements that are not due to the effect of a medicine. Importantly, in this study, and I'm not sure it would be that different today, the investigators also asked after the study, would you still think about this as a treatment for your child, even after seeing the results? And most parents said yes. And there were plenty of physicians who continued to prescribe secretin infusions for a period of time, even after these initial data were released. And we see for other fad treatments. And I'm not going to spend a lot of time talking about fad treatments, but I'm just going to show one more thing about the placebo effect. This is across a number of reasonably conceived studies where there was a placebo group in comparison to a medicine group. And you see across those studies, and this is particularly true for the larger studies, placebo oftentimes shows substantial benefit. There's sort of benefit that a clinician says, well, this child is much improved on this medicine, about 30% of the time, which is stunning to think about, but worth noting when we're talking about new treatments that somebody hasn't yet compared to a placebo. So that's an example of what we have evidence for not working. The medicines that have the most evidence for benefit are what I typically call mixed dopamine and serotonin receptor blockers, or mixed receptor blockers, but are known by a number of other names, including atypical antipsychotic medications. This is probably the term most commonly used by physicians who are prescribing these medicines. These medicines are aripiprazole and risperidone, or Abilify and Risperidone as the brand names. They are the only FDA-approved medicines in autism, but they are not for autism. They are for irritability, as the FDA, the Food and Drug Administration, describes it. But this was originally a checklist used to rate irritability, agitation, and crying. Most of the kids who were prescribed these medicines in those studies had significant aggression or self-injury, or tantrums that were so disruptive they could not be in a classroom. These medicines also, for those people who were treated because they had agitation or aggression, also helped with hyperactivity or defiance and stereotype behavior, but only in that group. That's the only group where they've really been studied. To just, again, show a graph so you can get a sense of the response rate, these are the clinician ratings of whether a child is much improved or very much improved, where you see the majority of benefit is already seen in the first few weeks of the medicine, with some improvement seen even out to 8 weeks. where about 3/4 respond to risperidone and many fewer on the placebo. And if you just look at parent ratings of irritability and agitation symptoms, you see, again, most of the improvement is in the first 4 weeks with some continued improvement further on. This is to say, if your child is taking one of these medicines, you should expect with risperidone most of the benefit to happen pretty quickly as the physician is titrating the medicine dose up. And that's what was done in these studies. These medicines also have a lot of side effects, weight gain being the most troubling one, but also sedation and risk of movement disorders. On the weight gain side, this was a reason many of us avoided these medicines for a long time. But we now know that using a medicine, Metformin, that's commonly used to treat obesity-related diabetes, actually can stop weight gain related to these medicines. So if you do need to use one of these medicines, if you monitor weight carefully, if the weight is creeping up too much, you can use Metformin to stop that weight gain. And to just, again, show that for illustration, you can see that over the first 8 weeks, Metformin really doesn't show an advantage. The advantage comes between 8 weeks and 16 weeks. So you have to persist with the medicine. And if you just look at weight change, this is the expected weight for a child at their particular age and the change in that. This is the weight change that's actually seen. You don't see weight loss. You see kids who are growing into their weight, who would otherwise be gaining weight if they were not taking the metformin. So that's it for medicines that are actually approved by the Food and Drug Administration for use in autism. There is some reasonable evidence also for medicines that treat attention deficit hyperactivity disorder in kids with an autism diagnosis. I describe this as the law of 50%. So dopamine reuptake inhibitors, sometimes called stimulants, including methylphenidate, can show significant benefit. And in the best study that's been done, that's about 50%, 49% who are rated as much or very much improved by the clinician who's seeing them, and have about a 30% reduction in symptoms. It's important to note that that's not a 50% reduction in symptoms. So these are medicines that help but don't resolve ADHD symptoms. Nearly 20% couldn't even tolerate the lowest dose of medicine used in these studies. So it's important to note that these medicines are more likely to cause side effects in a child with a diagnosis of autism. And that's usually irritability and agitation, which obviously is not something that we want to make worse. There's also evidence for norepinephrine reuptake inhibitors, with atomoxetine or Strattera being the example that's been studied. In the first study, this was compared to placebo at a dose that's the commonly used dose, 1.2 milligrams per kilogram. And I don't need to talk about sort of how that is escalated, but that's something that is done under the guidance of a physician, gradually working the dose up to that level. And only 21% of children were actually rated as very much or much improved, and 9% on placebo. It was still a significant difference, but not what we would want to have in the clinic. It was very well tolerated. And then in a follow-up study published a few years later, a little bit larger group was used, and the dose, importantly, was higher. Now 1.8 milligrams per kilogram, and now divided into a morning dose and an afternoon dose. And here they got nearly a 50% response rate. They did see more side effects. They saw more appetite suppression in particular, which is also a problem on methylphenidate and other drugs that block dopamine reuptake. So that's what we know, where we have multiple studies that are consistent with one another, that are at the level of evidence that we would normally have when we're prescribing something that's approved by the Food and Drug Administration. And it's important to recognize that, and that we as clinicians approach that with humility. And then we walk into the territory that I would describe as the haystack of uncertainty. There may be needles in there, but we don't have enough evidence to be truly confident. So I'm going to start by talking about a couple of examples where there's actually one large study that is well done and could be thought of as reasonable evidence. And then talk about those other categories where there's a little bit of evidence, but it's not particularly robust. So those studies where there's only a single example include guanfacine, which is what I think of as the third in my rule of 50%. This is approved by the Food and Drug Administration for ADHD. and has been studied in a moderately sized study in kids who have an autism diagnosis plus ADHD. This usually is prescribed these days with the long release formulation. The brand name is Intuitive, but it's available as a generic, which is what I usually prescribe. And here they saw 50% rated as much improved and only about 10% on placebo. It did have some side effects, sedation in particular, as well as decreased appetite and dry mouth. And then there's one well-done study of prolonged release melatonin. This is not available in the US. It's not approved by the Food and Drug Administration for anything in the US, but it is available in Europe and some other areas of the world. This was a pediatric specific formulation. The pill is tiny. It's a 3 millimeter pill and something that is designed to be easy for children to take. It was studied in a pretty large population, and you see that there was a big advantage both for total time spent sleeping, as well as time it takes to fall asleep. Really nice, robust effect. I wish we had access to it. I will note that we do have access to short release melatonin that you can pick up at most drugstores. This does help some with the time it takes to fall asleep. It also can help with sleep-wake cycle dysregulation. So if somebody is switching time zones, for example, or if somebody tends to fall asleep late and wake up late, it's used differently in those contexts. It can help kids fall asleep, but it doesn't lead to an increase in total time spent sleeping. And usually what you see is kids fall asleep earlier and then wake up earlier, which can either be helpful or hurtful depending on the particular child and family. So that's where we have single studies that are positive and clear. The next category is a single positive pilot trial. And I view these with more skepticism because they have a smaller sample size and it's hard to be confident. One example here is sulforaphane, which is just broccoli sprout extract, although prepared a particular way. And you see here that on a couple of different scales in a pilot study, only 40 kids, that there was a bigger improvement on sulforaphane compared to placebo, both for aberrant behaviors rated by parents as well as for social responsivity rated by parents. In this study, there was no placebo response, and there now is a published follow-up that is completely negative, unfortunately. That doesn't mean that it couldn't have benefit, but it means it needs to be studied in a larger population before we have confidence. There are other examples that we could talk about, most of them studied further back than sulforaphane, but I think that these are areas where you could see more evidence arise over time. There are also examples of mixed evidence, and I'm going to go through these very quickly. I will note that serotonin reuptake inhibitors have quite mixed evidence. In kids, there was a large study of citalopram, or Celexa as the brand name, although it's available as a generic, showed no benefit for repetitive behaviors lumped together. They did show some slight improvement in irritability and agitation, and they showed a differential response to placebo in kids who had less difficulties. So the kids who had less repetitive behavior, less distress, actually responded better to placebo than to citalopram. The opposite was true in kids who had more impairing behaviors and more distress. So further study is clearly needed. There's also a negative study of low-dose fluoxetine, used to be the brand name Prozac. There have been no studies of these medicines for anxiety or mood disorders that have been well targeted. And that's concerning because anxiety disorders and mood disorders are common in autism, but there's never been an adequately studied medicine for those difficulties in folks with a diagnosis of autism. The side effects on these medicines, I noted here on the slide, were quite common, almost half, and were prominently including what we describe as activation, which can be quite troubling. Increased energy, decreased sleep, impulsivity, and oftentimes rapid switches in mood or irritability. And so these are medicines that you have to use very carefully, start low, go slow. That's what we say in general in child psychiatry, but these are medicines that we are hesitant to use for some kids for that reason. I will note in adults, there are a couple studies that show significant benefit. I'm again showing one example here where you see improvement in obsessive compulsive disorder symptoms in the group that's actively treated with fluoxetine or Prozac in comparison to the placebo group, which does not show improvement. And you see at an individual level, most people are showing significant improvement, not resolution, but improvement. Importantly, this is in adults. This is in folks who do not have difficulty with communication and have an IQ that is on average at 100, which is average in the population at large. But this is to say these medicines may be useful when somebody has a diagnosis of OCD. There's similar data with another medicine in the same class with broader benefit and less well-defined outcome measures. And then there's some data for N-acetylcysteine. A particular preparation of that was studied called Pharmanac. That in one study seemed to lead to improvement in irritability and agitation in comparison to placebo. Again, almost no placebo response. In pilot studies, that always makes me nervous because we know in a larger study, you would always see a placebo response. This is a supplement, so it's available without a prescription, and it does have evidence for skin picking, hair pulling, or trichotillomania, or nail biting in the general population. And so you also can think about it in relation to a child who may have body-focused repetitive behavior like skin picking or hair pulling. So then we have a different category, which is clear evidence for absence of benefit. And I tend to think that if you have a large, clear study that shows no benefit, that can be enough. But sometimes people want to see two. I'll give one example here that is of Lorazepam, which is another medicine in the same class as Risperidone or aripiprazole. It's a mixed receptor blocker. The brand name is Latuda. And you see here that same checklist. You see that there are two different doses of Lorazepam that were tested, and neither one of them really looks better than placebo. And so it's just important to note, it isn't just any medicine in this class. There may be other ones that would be helpful, but we know some of them would not be. And then I'm going to use the example briefly of intranasal oxytocin, which I mentioned earlier that became sort of like secretin, a bit of a fad treatment for a period of time. This is in part because of studies, and I'm just showing one example, that demonstrated that receiving intranasal oxytocin compared to intranasal placebo actually could change social behavior. And it could change social behavior in the laboratory setting with a single dose administration, including in people with a diagnosis of autism. Shown here is a cyberball game. This person is throwing the ball to somebody who returns it to them, somebody who throws it willy-nilly, or somebody who never returns it. And in the quote unquote healthy population, I would say this is old terminology, but you're stuck with what's published. You see a clear preference for playing catch with the person who plays nicely. In the population with a diagnosis of ASD that received a placebo nasal spray, you don't see any such preference, whereas you do see a preference after receiving intranasal oxytocin. So this can clearly change social behavior in a single dose in a laboratory setting, but this is clearly not something we think of as diagnostic. There have been quite a number of other studies that showed proof of principle with single dose administration. And then there have been some, again, pilot studies, like what I showed you with sulforaphane, where a small group was either given intranasal oxytocin or intranasal placebo. And in some of those studies, but not all, you saw an advantage for oxytocin versus placebo. And this is on the social responsivity scale.
Sorry, could you say that again?
That advantage, sorry, I must have said SIRI. But in any case, in those studies, it was a little bit of a complicated story that you had to look at the pre-dose levels of oxytocin in the blood, and maybe that plus whether you received oxytocin or placebo predicted response. And so we, with colleagues led by Lynn Sikic at Duke currently, tested intranasal oxytocin versus placebo in a large population where we were able to look at subgroups, and we did not see any advantage of intranasal oxytocin versus placebo. I will say this is now a while since I've known these results. It was quite devastating to see initially because we were quite hopeful about these potential results, but you can see there's really no separation. And this is a measure of social withdrawal. But placebo, if anything, at points is maybe a little bit better, but at other points you can maybe think there's no difference whatsoever. Oxytocin is not better than placebo when given chronically over a long period of time, unfortunately. There's also an example of memantine, which was studied in a very large population that did not separate at all from placebo. This used to be under the brand name Namenda. This is still something that you will see prescribed for some kids, and I think we have to have some hesitance about that as well. So that's sort of where there's little bits of knowledge in this haystack of uncertainty. Sorry, you're seeing my puppy's head. She's distressed because I'm working from home instead of my partner. So it goes. I will say I'm not going to go through all of the medicines that have not been studied in comparison to placebo. There are many, many examples of things that have been given without that comparison group. And I just don't think it's worth the time. I also will note that there is a domain that I would describe as beyond reason. Instead of a haystack, this is a dung heap. And unfortunately, this is not a small area. Examples here would include chelation, which now is not in frequent use, but was. When I was at Vanderbilt in Nashville, there was a child in Nashville who died after exposure to chelating drugs. And the current example there would be umbilical cord blood infusion or embryonic stem cell infusion. Very frequently, this is something that is being charged as cash, not being paid by insurance. It's exorbitantly expensive. It's oftentimes done in another country. And it turns out much of the time, it's not even umbilical cord blood or live cells that are infused, but there now is a randomized controlled trial that shows no benefit whatsoever. So I'm not going to go through this category in detail. Happy to discuss it in the question and answer period. So, and that took me a little longer than I was expecting. Sorry. I get sort of wrapped up in giving maybe more detail than I necessarily need to, but I'm now going to talk about sort of when, why, and how we actually consider medicine, looking to balance benefit and risk. I will say it's important to note that because we don't have medicine that treats core symptoms, we have to think about the target of treatment. So as a physician, I always think about co-occurring medical problems first. If we're thinking about core symptoms or communication, we're not thinking about medicine. If we're thinking about psychosocial stressors, things that are causing difficult for the child in their life currently, we're also not talking about medicine. Primarily, we want to think about co-occurring disorders that we can diagnose, or the general category of irritability and agitation, as I noted. So I'm going to give an example here of, and it's fictionalized, but this is based on a few different experiences. So phone call to the physician, a 10-year-old boy struggling with ASD symptoms and anxiety over some period of time, but stable over the course of the last year. And then all of a sudden, the night before, he had punched the wall, threatened to kill anyone, his mom or his sister, who came close to him, and said that he wanted to die. He didn't actually move to hurt anyone. He did settle down. He went to sleep. That wasn't when I was getting the phone call. The phone call was the next day because he had told a teacher, if you keep saying that, I will punch you in the face, while shaking his fist. He was removed from the classroom, placed on one-to-one the rest of the week. And when I get a phone call like this, there are a few different questions, but one is he safe right now? And the second one is, has anything happened that might have triggered this? Not assuming that this is just a continuation of the difficulties that led him to be on aripiprazole in the first place. So safety, mom's on the way home to meet him. The school put him on the bus. This isn't that uncommon, but clearly if you're putting somebody on one-to-one for the rest of the week, you probably don't want to put them on the bus. A lot of questions about potential triggers led to the recognition that he had sprained his ankle the day before. He had been hobbling around wearing an ACE bandage, and he had not been taking pain medicine because of the concern about interaction with his current medicine. So what did we do? We did not send him to the emergency room for his behavior. We did not adjust his aripiprazole or Abilify. We treated his pain. And that seems really concrete. This was a 25-minute phone call where we sort of walked through, what could this possibly be? What are some triggers? What was happening at school? Until we recognized that this was likely due to irritability from being in pain. I was then available for an update. He ended up not needing to be on one-to-one for more than the next day, and he did fine. We didn't adjust his other medicines. So these sorts of situations are very common. Usually there is a trigger. Often the child cannot make the connection. Often it's not obvious to a parent, but we always think medical first: pain, infection, change in medicine. So it can be that somebody takes a new medicine, sometimes for congestion, like pseudoephedrine, and that triggers more difficulty with behavior. And then it can be something that's happening in the environment. I always think about trauma, and that can mean something different for somebody who may not be able to communicate as easily. Stressors, staff changes at school, conflict at home, somebody else who's upset, and then it's spilling over. So lots of examples of potential triggers. There are a common set of medical problems in autism. I'm not going to go through these in detail. We always think about seizures, which are common and have a second peak of occurrence in adolescence, so always need to be considered. When I hear about a story like this, oftentimes the trigger is worsening constipation, which is very common and often includes stool leakage, which can be confusing. So a child who has streaks in their underwear or may periodically have a little bit of stool leakage. Oftentimes that's because of constipation that is so severe that you get liquid stool reaching around, stretching around the edges. Tooth decay is another common one. Dental care is incredibly important in this population and oftentimes difficult to get. And so you always have to think about whether somebody has pain in their mouth. And then other things that are common: headaches, ear infections, minor injuries. Many people with an autism diagnosis won't say that they're in pain, but may still be irritable. And that's something to always have in mind. And then non-acute concerns. So frequently the complaint is this non-specific category of irritability, agitation, aggression, behavioral difficulties, broadly speaking. I'm not going to go through this figure in a ton of detail, but this is a pathway that we developed and published in pediatrics that's available for primary care physicians to walk through the possibilities. Importantly, thinking first about medical problems, difficulties with communication. Sometimes aggression is the only way a child can communicate. Psychosocial stressors that can be triggers. Maladaptive reinforcement, something that inadvertently is getting rewarded. And then co-occurring psychiatric conditions. And I'll walk through this a little bit. So when we think about this, we're thinking about medical and sleep workup first, then addressing psychosocial stressors, which is very different child to child, improving communication, improving reinforcement patterns next. And those are behavioral interventions. And then treating co-occurring disorders before coming back to that category of irritability or agitation. Okay, so on the communication front, you try to very simply provide an appropriate communication strategy to replace the aggression or the tantrum. That can be a wide variety of things. I'm not going to spend time going through the detail, but the key thing is that you are reinforcing the appropriate communication with the desired consequence instead of reinforcing the aggression or tantrum with the desired consequence. That aligns very well with the approach in ABA, where you're really thinking about what is causing a problem behavior to persist. That can be delivery of a preferred item. So it can be getting access to something. It can be removing something that is painful or not preferred. So that can be escape from a classroom, which is a very common one. A kid who gets aggressive and then gets sent to a quiet room, right? Well, the quiet room may actually be a nicer place to be than the classroom at that particular moment. And so you have to change the paradigm so that you're now reinforcing what it is that you want to see and no longer attending to the behavior that is causing a problem. So you don't want to keep reinforcing that. Oftentimes you're reinforcing an alternative, and this is where communication is the most common thing, that you're trying to get another approach to communicating a child's wants and needs. We know that this is helpful. We know this is helpful from a lot of small studies. And then this is one example of a large study where a parent-mediated approach that's based on these principles outperformed a comparison that was just a psychoeducation intervention, where parents just heard about the causes of autism or difficult behaviors. So, and then importantly, we don't just want to think about whether a child has symptoms that extend beyond autism. We really want to make a diagnosis. This is what we do in psychiatry, broadly speaking. It doesn't mean the diagnosis is a disease, but it means that we want to have something that's clear enough to guide our treatment. The most common of these in autism, and I'm not going to spend a lot of time talking about them, it could be a whole separate talk on each one, would be attention deficit hyperactivity disorder, anxiety disorders, obsessive compulsive disorder, or mood disorders like depression. This is the example of a pathway to evaluate ADHD in autism. So like when we're thinking about irritability and agitation, you don't just say, well, the child's hyperactive and they're not focusing, so they have ADHD. You want to understand, does that relate to difficulty sleeping? A tired child does not focus. Could the child be having seizures? Is there something else happening like anxiety that is distracting the child from being able to focus? And then evaluating whether you can improve their structure, their classroom, to allow them to better focus without needing to think about medicine. And then you pivot to thinking about medicine that is specific for ADHD. And that falls into that category, you know, the law of 50%, where you're going to be walking through those different options. If you go through this pathway from medical problems to potential psychiatric comorbidity, and you can't come up with a better explanation or treatment option, then absolutely you think about the risperidone or aripiprazole that's approved by the Food and Drug Administration. I always first think about whether there's a significant impulsive component. And then I sometimes will think about the medicines for ADHD to try to see if I can improve the impulsivity and decrease the aggression or self-injury. And then I think about medicines in that category. And this is just to say, there are other things that can be considered that have some evidence. And some of these I walked through, some of them I didn't. But it's important in this situation to be working with a child and adolescent psychiatrist or a really experienced pediatric neurologist or developmental pediatrician who has walked through this pathway with many families in the past. So that takes us to one example, and I'm going to try to wrap up in 5 minutes so that there's time for questions. And this is fictionalized, but based on a number of experiences. We'll call her Janna. And the presenting concern, and this is oftentimes the case, is yes, a child with a diagnosis of autism spectrum disorder, but a child who's presenting with difficulty with ADHD and aggression. She came to me at 7, and this was her history. She came in as a consultation. She had another physician who had been prescribing medicines previously. She was having difficulty with ADHD symptoms at school. She had significant anxiety around change, and it was a little unclear whether that was insistence on sameness or always the question, just a desire to have things the way that she wanted, but certainly some insistence on sameness. She was pinching her mother when she was frustrated, and that was leaving some marks, including a bruise that I was able to see in the clinic. She was doing some pushing of other kids at school. And in clinic, what I observed was only stereotyped or repetitive phrase speech. So hearing the same phrases repeatedly and not hearing flexible use of language. To date, the treatment approaches had been on the communication side, only verbal communication, talking to her, asking her what she wanted, what she needed, and telling her what she was supposed to do. A discipline approach that was primarily using a threat of day-long loss of privileges, which sometimes then was carried forward, which led to more distress, and sometimes that was a trigger for her pinching behavior. She had had medication trials for her ADHD and for presumed anxiety. That had included methylphenidate or Concerta in this case, where she had irritability. It had included guanfacine or Intuniv, and she had had some improvement on an initial starting dose, and then at 2 milligrams, because her blood pressure was not checked in between and it was increased too rapidly, she actually had a fainting spell. She also had dose-limiting mood lability, this rapid mood shift that I talked about with activation with citalopram or Celexa that led that to be discontinued. So our next steps, and I'm a child and adolescent psychiatrist, this is focused on medicine usage, but our next steps were not focused on medicine. The first thing was to shift to a mixed visual and verbal communication approach, a visual schedule so she could anticipate changes and was not distressed by them, and a picture exchange communication system that was particularly emphasized when she was feeling upset. We also pushed to shift the behavioral approach to short-term rewards for compliance, for doing things that we want her to do, instead of long-term punishment. And part of the principle here is if you remove privileges for the whole day, you've lost your leverage. And the child oftentimes feels like that whole day is ruined. And so it's really hard to rebound from that and then see an improvement in behavior. And it's incredibly distressing. On the medicine front, well, we switched the guanfacine to nighttime because it is a sedating medicine and it can lower the blood pressure. And so we wanted the highest blood level of that medicine to be while she was sleeping. And then over time, we increased that to 2 milligrams at night, which she then tolerated well once her body was used to the medicine. Importantly, you have to monitor blood pressure on that medicine. And then we thought about atomoxetine or Strattera, in part because it might also benefit anxiety. We didn't end up needing to go there once we improved her communication and discipline approach. We could have thought about a mixed receptor blocker, right? So I've told you that the Food and Drug Administration has approved them and for some of the things that Janna was struggling with. We didn't do that. Well, we could have seen benefit, but the why not is important. So in Janna, she had some family history that suggested risk of diabetes and risk of weight gain. So that was off-putting. And then these medicines are also associated with risk of movement disorders, including one that's called tardive dyskinesia with prolonged exposure. And then importantly, her communication and behavioral supports had not been optimized. So it wasn't really necessary to go there before testing another approach first. And when I think about these medicines, I really try to hone in on these key questions. So first, is someone getting hurt or likely to get hurt? And that's not always obvious, but it's something that we can ask ourselves and partner with a family and sometimes also the child around. That can include extreme impulsivity, like a child who's opening and now you should have child safety locks, but opening the back door of a car while it's moving, or diving over the front seat because of a level of agitation. And then importantly, is a child likely to lose access to educational or other settings without intervention? And that is important. So if a child is in a classroom that's a great fit for their abilities, but not a good fit for their behavior, importantly, we first try other things, but we sometimes do use these medicines even if nobody is likely to get hurt because other approaches have failed. And it is important to include in there, when other interventions have failed, there oftentimes is a level of distress that merits using these medicines. Even if nobody is getting hurt, the child is so regularly distressed that it would be reasonable to think about a medicine that would reduce that distress. So I've walked through quite a lot here, and now I have 14 minutes at least for questions. But just to note, we do have evidence for some medicines. We really have to think stepwise about other things that could be causing behavioral difficulties before we lean on what we have evidence for because of the level of associated side effects. And when we're thinking about doing this in the real world, we're really thinking about making clear co-occurring diagnoses like ADHD, anxiety disorders, and targeting those instead of thinking that our medicines are actually going to benefit core symptoms. And thank you for your attention. I will stop there. And I do see that there are a number of questions in the chat.
Thank you so much, Dr. Veenstra-VanderWeele. This was really informative. And we have, like you said, quite a few questions. So I'm just going to jump right in from top to bottom here for you. So starting off, some autistic adults have had a negative experience with medications prescribed as children and are now experiencing CPTSD as a result. When is medication recommended for childhood meltdowns, and are there other interventions that might work? I think.
Yeah, so I would say I've walked through a good deal of that. When I've seen folks who clearly have trauma-related symptoms, sometimes formal PTSD, sometimes not. It's more common actually that it's not medicine-related, although sometimes it's in people who have experience being in emergency room or inpatient hospital settings and they've gotten shots, which can be very traumatic. But more commonly, it's actually restraint, or it's other experiences around episodes of agitation. So somebody being held down can be incredibly traumatic. Other people's response to being upset can be incredibly traumatic. The specific medication exposures tend not to be traumatic, even when there are associated side effects. So it tends to be receiving the medicine. So that can be being held down in order to get a shot. Sometimes it's the process of being forced to take a medicine. Those are things we always try to avoid, if at all possible. And it should be really last resort when somebody is actually putting hands on. Almost all of the time, if you back away, episodes of agitation tend to be self-limited. So if you can make sure that somebody is safe, remove other people from a situation where they could get hurt, most of the time, somebody, any of us, will calm down over time. And we need to let that happen instead of intervening, instead of causing trauma. So I'll stop there. And I actually see one in the Q&A that's one of my favorites, because this happens very frequently in clinic. What is my view on genetic testing for responsiveness to medicines? It has almost no utility whatsoever in autism. In fact, more of the time it interferes with being able to do the right thing than leading to benefit. And the reason for that is that we have very limited evidence, and our evidence is based on studies done in the overall group. And sometimes people do come in if their pediatrician has sent one of these genetic panels for medication response. And the panel says, well, less likely to respond to risperidone or aripiprazole. So that could lead you to start something that doesn't have any evidence whatsoever. And when you look at the actual data, what it oftentimes means is either somebody will respond to a lower dose or a higher dose of that medicine. And that's the approach that we take anyway. We start at a low dose, we gradually work our way up, attending to side effects. It's exactly the same approach you would do in somebody who had one of those pharmacogenetic findings. And some of that is also just based on baloney. It's based on studies that were not well conducted. So I never send pharmacogenetic testing, with one exception, which is that there are medicines that have an increased risk of rash. I haven't talked about them at all today. In particular populations, the South Asian population and East Asian population in particular, where before starting those medicines, which are lamotrigine and carbamazepine or Lamictal and Tegretol, it's important to do that testing. But otherwise, they have no use whatsoever.
Great, thank you. And I think another question I saw kind of floating around some stuff on the topic of puberty in chat. So are there any special concerns around puberty and medicines? And is there a correlation between the onset of puberty and the need to start medication for a patient specifically that maybe didn't need it in childhood?
Yeah, that's a good question. So multiple things happen together, and puberty and growth happen together. In my experience, it's actually more often how big a young person is than it is puberty itself that predict needing to start medicine. And oftentimes it's a situation where the child is now larger than one or both parents, and behavior that previously was not as difficult to manage at home has become frightening, or has become really problematic, meaning somebody's getting hurt. I try to think in advance of that. If we watch how kids are growing, if a child is 10 or 11 and having the sort of behavior that the parents are only able to manage because they can put a hand on the child's shoulder, or sometimes the parents are actually using some degree of restraint or holding or moving the child to a different room. In that situation, I'm thinking about those medicines because somebody is going to get hurt in 2 or 3 years instead of somebody getting hurt tomorrow or a week from now. And so that's important to keep in mind. Interestingly, the other thing that's happening during puberty is brain development. And so with puberty, some kids, a lot of kids actually, have less difficulty with ADHD symptoms than they ever had before. And that really works in your favor. There are also certainly kids who have more mood swings during puberty than they've had before, but there are also kids who settle down some. And then there are the inevitable shifts in affiliation, where prior to puberty, most of the affiliation is with the family. Kids oftentimes feel most connected to their parents, and that tends to be true for peers, as well as individuals who may have an autism diagnosis. after puberty, and certainly, late in middle school and into high school, the expectation is that you shift to primary peer affiliation, and that can bring with it a lot of strain. Doesn't have to do with puberty, but certainly has to do with the social consequences of puberty. And that, I think, has to be taken into account and can lead to challenges. And lastly, sexual interests can develop clearly more after puberty than before, and that can be a source of significant behavioral difficulty and frustration. And it is important to think about the appropriate sex ed approach for a child's developmental level, as well as their stage of development, physical development. And that most appropriately happens well before you've seen problems, and oftentimes is neglected in this population.
Great, thank you. Another topic that's sort of been swirling around in the Q&A box is anxiety and other mental health issues. And so people generally sort of asking for comment on your thoughts on medications for those sort of co-occurring conditions.
Yeah, so I wish that we had good evidence for medicines for anxiety in autism. We really don't. We don't have medicines that have been adequately tested. There is a trial going on in Canada right now of sertraline, which used to be the brand name Zoloft, for anxiety, which we know is very effective for anxiety disorders, which we know is a very effective treatment in the broader group of kids without an autism diagnosis. We do have evidence, however, that cognitive behavioral therapy approaches that are adapted for autism can be quite helpful for anxiety disorder diagnoses in autism. Unfortunately, it can be hard to access that. And that right now is true in the general population, as well as the population of kids with an autism diagnosis. The easiest way to access is usually to go to an academic medical center, which is more likely to have that, but it can be a challenge. And it isn't just any old type of therapy. It's very carefully done therapy. It is available as a manual online as adapted therapy. And so if you can find somebody who's expert in cognitive behavioral therapy, oftentimes they can learn to adapt it appropriately in autism. And that is, I would say, one of the first steps. The other thing to recognize is anxiety is normal, right? If we weren't anxious before looking to cross the street, we'd be hit by a bus. And if you have a set of difficulties that make it harder for you to understand the world, understand other people's intentions, that appropriately is going to lead to anxiety. And so things like social stories dramatically decrease anxiety. The intervention for anxiety in my example was not a medicine. It was to provide a visual schedule and then to provide a communication strategy that allowed her to communicate appropriately even when she was upset or nervous. And so that oftentimes is the way to go. When I do make an anxiety disorder diagnosis, and I've seen young people with an autism diagnosis who have panic disorder, sometimes with or without agoraphobia, who have generalized anxiety disorder, worries that are out of proportion to actual risk, who have social anxiety, crippling social anxiety, despite actually having relatively strong social skills, having a lot of difficulty putting themselves in a social situation. And when you can make a clear diagnosis, you can still use the medicines that have been tested for anxiety disorders in the general population. I usually would suggest only doing that in consultation with a physician who regularly works with the autism population and can differentiate between what I call anxiety due to autism and anxiety that clearly is an anxiety disorder, and would be an anxiety disorder whether or not somebody has an autism diagnosis. And that's what's being studied in that Canadian trial.
Great. I think we have time for probably one more question. Again, seems to be another popular question in the chat, just about the use of CBD as medical treatment for autism.
Yeah, that is a good question. Right now, CBD, I thought about using it as an example, is sort of a fad treatment for almost everything, right? People put it on their knee because their knee is sore. People take it because they think it makes their anxiety a little bit better. And certainly I've seen a lot of folks with an autism diagnosis who are receiving CBD. The data on what CBD helps for in comparison to a placebo is pretty limited. It is clear that it can help in substance use disorders. For people who have an addiction, CBD seems to make it easier, at least with cocaine, to stop using. We don't know why. Frankly, we don't know exactly what CBD does from a molecular perspective. Everyone feels like CBD is helpful for anxiety, but it turns out that anxiety is one of the things that responds best to placebo in the short term, not in the long term, but in the short term. And a couple of my colleagues at Columbia actually said, well, does it really help with anxiety? So they compared it straight up with the placebo. No difference, no advantage of CBD over placebo. Nobody has adequately tested it in autism. And importantly, much of what's marketed as CBD has maybe a tiny bit of CBD, maybe not, maybe a lot of CBD, maybe not. It's really hard to know because it's not regulated. And then a lot of it also has THC in it. And we do know that THC in anyone gets them high, right? And so if you're taking a cannabis derivative that contains CBD and THC, and you're seeing behavioral change, the behavioral change usually is from the THC. And that sounds okay. A lot of people feel good when they get high once or twice. Some people really feel bad. But we know that chronic exposure to cannabis, to marijuana, leads to risk of psychosis, risk of depression, and if you follow people out a decade, a risk of having a lower IQ, so actual lower cognitive function if somebody has been chronically using marijuana. Those are not minor side effects. They're not things that are visible when you first take the medicine. And so I think it's important to recognize those risks. And I'm really hesitant to have people with autism take THC. I don't think it's fair to expose somebody to those risks with that level of uncertainty. In the same way that I think most of what medical marijuana is used for is not well studied, well qualified. On the other hand, there are situations where somebody has tried everything that's reasonable, where I fully understand why families would try marijuana. I don't necessarily think that's a lot better than people who drink alcohol to treat their anxiety, but it is better. Just the degree to which it's better is unclear.